Welcome to the Low Carb MD podcast. No one is beyond help. No one is beyond hope. Nothing said on the Low Carb MD podcast is medical advice. Please consult your own doctor before making any lifestyle changes.
Hello and welcome back to the Low Carb MD podcast. Tro, this is going to be an easy one because we're going to fix medicine in about 5 minutes and then we'll just talk about other stuff after that. It's a simple thing.
The next 40 minutes is going to be important to listen. If you're a doc out there who's tired of the conflicts of interest in medicine, if you're tired of the conflicts in pediatrics, if you're tired of the perverse incentives in medicine, starting from the hospital networks and the facility fees and the bloat, all the way to the insurance companies and the PBMs and the regulations that are really binding medicine and ruining medicine, like we all know, you're going to love this guest. If you're a young doc, you're going to love this guest. If you're an old doc, you're going to love this guest. And if you're somebody who wants to sort of break free from the corporate and hospital system monopolies that are strangleholding medicine, you're going to love this guest. Today we have Dr. Marion Mass. Am I pronouncing that right?
Yeah, okay, just like perfect. Catholic Church.
Yeah, Marion Mass, perfect. Love it. And she is a board certified pediatrician, and she caught my attention with her fierce advocacy. I mean, for years, really, more than a decade, to really take back medicine. She also has co-founded Free to Care, right? Which I'd love to talk about her non-for-profit a little bit. And just as a point of reference, she she went to medical school at Duke. And where did you do your pediatric training? Where was the pediatric
at Northwestern. It's now called Robert Lurie Children's Hospital.
Northwestern. So we're happy to have you here. Yeah. You're such a fierce advocate on social media, and I've read your work. I've watched a couple interviews. I appreciate you coming on.
Oh, thanks for having me. I'm delighted to come talk. What can I tell you?
Well, I'm going to tell you, the maybe what we could start before we get into. Actually, we could start with the problem. Help me understand the problem in medicine. We understand it, but the listener may not understand it. What has happened to medicine over the last several decades, and where are we now? And maybe we can just start with the problem as you see it.
Well, I guess what I would say is everyone discovered long ago, probably back in the 60s, that healthcare was a juicy financial pie, and they all swooped in to get their serving, didn't they? And if you think about healthcare, what we really should have is we should have education geared towards a patient staying healthy. And then we do need sick care too, right? And that is what, physicians are trained in. But over time, the people that came in to gobble up the juicy healthcare pie, to take their piece, they offer less and less value to the patient. So the patient is not able to get what they need, and they're paying more all the time. And we have our current situation. If you look at the United States healthcare spend, and I remember writing one of my first articles to say, unwind the consolidation, expose where the money is going, give us some transparency, get rid of the conflicts of interest, the basic things that should have been happening. And at the time we were spending 3.1 trillion, and now I think we're at 5.2 trillion. So we keep on saying that there's problems, but we keep on letting a lot of suits be in charge of healthcare. And meanwhile, the scrubs, which include, physicians like us, bedside nurses that take care of patients, dentists, pharmacists, PTs, OTs, all the people that actually lay their hands on the patient to heal them when they're sick, they're getting squeezed. More is put upon them, more paperwork, more patient care, more to do, because the cost keeps on going up. And the people that are taking the money are the people that aren't actually seeing the patient. It's the bean counters, the paper pushers, the administrators. We know there's a big administrative glut. So I think we need to think about the healthcare pie, and we'd be much better if we could break it apart and ask ourselves, what does a patient need? And how can the patient become a part of that? And then who's above the patient that can offer them, I don't mean to say above in power, but who's able to offer the patient what they need? And why don't we just take everyone else and sweep them the heck out of the room? Medicine is our house, right? It's defined by our training. Why are we in this horrible position where we're not able to care for our patients? We're not able to fulfill our oath.
I think you're preaching to the choir, and I think it's hard for the average person to understand it. They're like, well, I get this insurance, I get it every year. I go to my doctor, and who's in network, and he sends me to the hospital, and ooh la dee da. And that's the extent of their sort of understanding. And I think you and I know how many barriers are in between all of that. So,
Sure.
you know, what do you think about the sort of the barriers to getting good care and how some of the incentives lead away from good care? I'd love to hear your thoughts on that.
Well, so first of all, one of the great problems that we've created, and we have to start thinking about it in a new way. We've created the problem of the American people think, oh, if I have this card that says I have coverage, a little card, I'm covered, I'm good, everything is paid for. And when we started, long ago, health insurance was insurance. It was true indemnity insurance, where it paid for things that were very costly and unanticipated. A car wreck, an appendectomy, the diagnosis of cancer. It paid for things that we needed to have to be insurable. Over time, we morphed healthcare. We actually outlawed what I call catastrophic insurance under the Affordable Care Act. It outlawed it except for a very small percentage of the population who were under age 30 and that met a low economic threshold. But we outlawed it for basically everyone, catastrophic insurance. And then we started, well, I shouldn't say we started, we accelerated the process of having the third-party payers, which include Medicare, Medicaid, and the commercial insurance. We accelerated the process where they pay for every little instance of healthcare, right? So if you fall, your baby falls, they're 3. They get a chin laceration, and the chin laceration needs to be sewn up. Well, you and I both know that a direct primary care doctor will do that in his office when you pay the membership. Membership tends to be about $90 per year per adult. I think most people charge about $30 per kid. And then if you have a passel of kids, it's less for each succeeding child, right? Well, that's going to be covered underneath your direct primary care membership. But if you're covered under a usual indemnity plan, something that could have basically cost you nothing and that really didn't cost the direct primary care doctor much to do, now all of a sudden turns into a $285 bill if you go to urgent care, and it'll probably turn into maybe a $4,000, $5,000 bill if you go to the emergency room. So why are we foolishly not doing the simple math and asking ourselves, if we insert a third-party payer into every instance of healthcare, it's going to make every instance more expensive, isn't it? So why aren't we uninserting the expensive third-party healthcare wherever we can? So it's why I'm a big fan of the direct primary care model. I don't practice it, by the way. I didn't know if you realized that. I am an employed physician. I don't speak for my employer, but I can certainly see that when the doctors that I know are doing direct primary care, what they're able to uncover is basic routine, everyday, non-emergent health care. It's not expensive. Why are we paying more for it? Because we've allowed ourselves to be dragged into this model where people equate my little card that says that I have coverage with care. And what has that done? The other part of the equation is that when you insist that you cover every little part of healthcare, then now all of a sudden you're making the doctor who's giving the care click a whole bunch of boxes, meet a whole bunch of metrics, do a whole lot of unnecessary work. That doctor really should have just been spending time stitching up your 3-year-old who split their chin open, and then your 3-year-old will be back home faster, able to sleep, you'd feel better, you spent less of your own money and everyone else's money.
Those are all huge points. I think that's so important. I was in the standard care for 18 years, and I just said, I'm clicking boxes. You have to do all this crazy stuff. They send you to class to upcode everything because ultimately, and I'll tell you, when I left, the crazy thing happened. I was making good money. I just couldn't take it anymore. I was working 17-hour days, just beat up and working on, you know how it is on the treadmill, going too fast. You can't keep up. And ultimately, I resigned, and the head of the HMO called me in and met with me. He goes, "Brian, what's wrong with you?" I go, "Look, I'm spending a lot of time with patients, preventing, like I go, look, I had 11 patients come off insulin in 6 months, just working on lifestyle and stress, but it takes time. You can't do that in an 8-minute visit." And I said, "Do you know how much money I'm saving you? Diabetes is the number one cause of everything, all of your expenses that you're paying. And I'm saving you money and you're penalizing me because you don't reward that. Preventive care, you don't reward that." And he said, "Well, Brian, you're actually costing us money." And I said, "Well, how can that possibly be? By saving you money, I'm costing you money." He said, "If they get those diagnosis codes, if someone gets diabetes, dialysis, amputation, bypass surgery, we get paid more by the federal government." I'm like,
Yeah.
who's the one having a midlife crisis here? This is crazy conversation. Is this why you went into medicine? And the more we see that perverse incentives, it's just so hard for someone like us who wants to, you want to help your patients and doing direct primary care. I spend way more time with my patients now because I can, and I'm not seeing a million patients who don't really care what I'm saying. They're investing in their health, and it totally changes the whole dynamics.
And they trust you and they have a relationship, so they're more likely to be, compliant with, things that you're suggesting. But, listen, let's be honest here. We do have to, I think, as Americans, accept the fact that we're typically not we're not the model of health. How about I say that, right? And I do think it's wonderful that we're having the conversation about the processed foods, and we need to kind of get those out of our diet, and we need to talk about eating real foods, and getting back to eating a healthy diet, eating, you guys are the low carb people there. I fell into low carb when I first got pregnant 27 years ago because I thought to myself, gosh, if I keep on eating this pasta and I eat all the protein they tell me I really need for pregnancy, I'm going to blow up like a balloon. So I dumped the carbs, stuck to the protein, and I've done it for 27 years. I'm not going to say I'm a supermodel, but, I do okay.
Awesome.
One of the things I've noticed in primary care and in direct primary care, and this goes back to incentives. So we have nationwide contracts with LabCorp, Quest, BioReference, and we get rates, and I can't say them, but let's say, at a typical hospital, it'll be $1,200 for lab work. Right. They'll charge the insurance, maybe $1,500, negotiate down to $1,200. Those same labs with our contracted rates are maybe a fraction by 1/10, right? Around 1/10. Now, imaging is the same issue, right? We have imaging partners all throughout the United States. And let's just say chest x-ray could be, 1/10 the cost at a university hospitals or a corporate network, large network. So, and by law, I'm not allowed to upcharge. I have to pass those on directly because of Stark law issues. We cannot make any money, with those two things. So we have to, by design, we have to, whatever savings we expose has to go to the patient. But the hospitals go around, they want to buy us out. They want to buy us out because they immediately make that spread. Any lab we're ordering, right, when they buy us, they immediately make, maybe 5-10 times more. They get to charge a facility fee to the insurance company the minute they buy us. So they get this natural spread. So I want you to talk about conflicts of interest, in the way the insurance system is set up. And I'd love to hear you go back, and tell us about the conflicts of interest you've uncovered throughout your career, because I think some of those are pretty exciting.
Pretty exciting, huh? Okay, good. Well, listen, I don't do direct primary care. I think it's like absolutely outrageous, though, that you're not allowed to, I guess, spout to the public what great rates you're able to get for your labs and your imaging, is what I'm hearing.
Yeah.
But one thing that I want to speak for right there is what you do have is a transparent model. So when you present it to your patients, you're able to let them know that you can get their labs and their imaging at a very reduced rate, correct?
Correct. Yep. At about
So
one.
you're,
Yeah.
yes, and you're being very transparent because what you're telling the patient is, okay, you pay me this membership and I've hustled and I've negotiated on your behalf and gotten terrific rates, which I'm going to pass on to you for lab work, for your MRI, for your CAT scan, for uh, your foot
Yeah.
X-ray when you whack your foot into the side of the cellar because you're running too fast through the house, right? So you're able to show your patients those rates. It would be really great for patients to kind of get up there that have a terrific thing going to let everyone know, because what you've proven right there is how transparency can really truly drive prices down. Because the cost of those labs and the cost of those x-rays is not high, but the price is high depending upon where you choose to go. And this is very likely why we're having hospitals and insurers fight price transparency rules. Right now, since 2019, I guess it was implemented in 2021, but we've had a price transparency executive order that was written into rules. And I believe we have only 21% of the hospitals fully compliant, which
Yeah,
is
they
absolutely
do a spreadsheet with a bunch of numbers on it. It's not even, it's not even legible. Most people can't make any use of it, right? I think that's supposed to change,
By
but it hasn't
design.
changed.
Yeah, it's by design because so used
but
to I have no idea. It's like all crazy. But yeah, like what
exactly.
Tro's saying, and it's so crazy, and we all know if someone, for instance, just happened 2 weeks ago, I had a patient come in with she was getting her bag off the airplane and ripped her rotator cuff. She couldn't lift her arm and she was miserable. And so insurance says, well, you're gonna have to do 6 weeks of physical. Clearly has a rotator cuff tear. You're gonna need 6 weeks of physical therapy, then you have to have an x-ray, then you have to do like all this stuff she had to jump through. Like you have a torn rotator cuff. I'm pretty 100% confident of that. If you pay cash, you get it for she goes $300, MRI, torn rotator cuff. She's in surgery. Otherwise, she'd be going to like, that's a waste of resources. You're going to do 6 weeks on something that's not repairable. It's stupid. And
6 weeks of pain.
it's suffering the
So
patient because they go, well, a certain percentage of people will end up not getting the MRI. So we'll save money in the long run, but someone suffers all this time. So it's to see how the system works. You go, and the other thing, and I think we've all experienced this. If I order a bunch of labs through Medicare on a patient who's 80 years old and he wants his PSA checked and it gets denied by Medicare, the labs comes back at the patient, even though they get paid $12 for the whatever, $9 or $12 to do the test. They go, you owe us $100 for the test. Like, because that's what we charge if it gets denied by Medicare. We go, that's not what Medicare is paying you. Why don't you ask them to pay you what Medicare would have paid you if they went through? No, that's not how we do it. And you see how crazy this system is that they overinflate all these prices where they're not getting paid that. So in primary care, the problem is, especially with Obamacare, is that these people have they're already broke. They have a $10,000 deductible. So if they go see a doctor who's not their primary, then they have to pay. The doctors are like, well, this is what we're billing, but the insurance company is paying them a fraction of that. So why not just bill the patient what the insurance company is going to pay you? Yeah, it's
yeah,
just
it's
gotten so
wild.
wild.
But you know what? The big flashing neon sign from the patient's perspective is if you guys are able to do it for the low cost of X and someone else is charging 10X, the big flashing neon sign should be why pay more? Right? So like they should be asking whoever they're going to, hey, down there they're able to do it for less. Why are you not able to do it? What's tying your hands? And the question has to be asked again and again and again until people drop their prices. If you have a transparent model and you're showing that you can get it for less and it's the exact same quality, then how foolish are we to keep on paying through our little card? Remember the little card?
Well, let's talk about that. It's has to do with a little something, and I think we all know it, called the medical loss ratio, right? The insurance companies and the institutions both, they don't want to give their competitors a competitive advantage, so they want non-disclosure agreements so that Tro can't tell Brian how much he's paying for labs, right? And then what they want to do on top of that is, they win when the prices go up. The medical insurance companies, people don't realize this, they are capped to make money at a fixed percentage of the top line. They can only make 20%. So if you're an insurance company, what do you want? You want that top line to go up. You want it to go up slowly. You want it to go up reliably, because then the profit you can make, which is 20%, goes up. So, and this is a huge, huge, huge problem. And I know we all know it, but you've been pointing out conflicts of interest, and we're highlighting, I think, the biggest grift in medicine right now. But you've been highlighting conflicts of interest for a long, long time. So I'd love to, I don't know, Brian, if you agree, I'd love to go back. What brought you to medicine, and hear that and talk about, what happened, because you called out the AMA and you haven't stopped calling them out since. So I'd love to hear about that.
Oh, sure. Yeah, we'll have a good time talking about this. And I will tell you, I actually know some really wonderful members in the AMA that, they always tell me, I can fix it from within. Marion, please come join. And I'm like, not with those conflicts of interest. I guess we'll get to those presently. You asked for my story. What brought me to medicine? Yeah, I grew up actually in rural Pennsylvania, but then it was rural. Now it's more suburban. I am the only daughter of 5 children. Neither of my parents went to college. I used to go hunting with my father, actually. And then I was so fascinated with the internal organs. I would dissect the squirrels, dissect the rabbits. I know I'm probably grossing some of your readers out. And by the way, my father ate everything that he hunted, so it wasn't like there was any waste. And my mother was horrified that her only daughter was in the garage, like pulling guts out and looking at kidneys and that sort of thing. But anyway, I ended up going into medicine. I thought I was going to be a research scientist. I worked for Merck for several summers as an intern, and I did research in cardiovascular pharmacology. And I started at Duke Med as an MD PhD funded by the NIH. Got to my second year when we did clinical work, fell in love with taking care of patients. I had never done it before. It just kind of felt like this is so natural for me, right? Talking to people, working with them, figuring out their problems, working alongside of them to solve them. And doing so in an environment, I'll say that Duke Med was old school at the time. I don't know if it still is, but the doctors, the scrubs ran the place, and there was not the suit, the pervasive feeling that we have from suits like we do now. So in any case, I gave up my fellowship, but they had already paid for my third year. So I was out of Duke Medical School for 1 year's worth of tuition. And in those days, and it wasn't that long ago, I started in 1990, the tuition was $14,000 a year. It's not that now, but in any case, I then went residency, chose pediatrics, finished the residency, worked for a couple of years as a hospitalist, and then I started having children. I married my husband, who I met in medical school, and then I decided I was going to work nights and raise the children, which is it's so not everyone else's path, right? But I just decided I'm pretty good at not sleeping, and I was capable of doing this, so I did. And so, if you take a look at the overall cultural problem of what I would call the mommy wars, where everyone's arguing over how you raise your children, I found something that worked for us. And then I became the mommy who moonlit. So I was in the schools, being the homeroom mom, helping with lots of stuff in the schools, helping with their wellness programs, putting gardens in schools, all kinds of things. I had a ball. And when I woke up enough that the kids were all old enough and all in full day school, I took a look around medicine and I was like, wait a second. I felt like Rip Van Winkle. What in God's name happened? When I was in medical school, the scrubs ran the show. Now all of a sudden, like, I'm going in and they're saying, here, you have to use this EHR. And I'm like, but this is so unintrinsic. This is terrible. This is going to take me 3 times as long as that. this is the way that it is. We have to pick something that works for the government, that, follows, meets their approval, and we're just making the decision for you. You can't do that. We're the doctors. And like everyone else is just kind of asleep, like they had been beaten down. So I didn't understand what had happened. And then I thought, well, I'll start taking a look around and figure out how could I advocate? Because this just doesn't seem right. It seems like it's going to hurt patients. We're already costing too much. We're just going to cost more when we add a government approved product in here. And I ran into organized medicine and I didn't like what I saw. And then the more that I dug, this was soon around the time that Obamacare was passed. I didn't like the plan. There was lots that I had to say about it at the time, but I couldn't believe that the AMA backed it up. And then it was then that someone pointed out to me that the American Medical Association, they have a particular conflict of interest, and their conflict of interest is they earn royalties from the coding system, the CPT coding system. So if you're working within the insurance model and you want to get paid, a CPT code is part of the process. The Obamacare plan was an insurance plan, right? Because it demanded that everyone had to have an insurance model. So it was going to help insurance prosper, which obviously it did, right? I mean, we can all see it. We can see that the insurance companies have become very wealthy and very powerful, but the AMA had that peculiar conflict of interest. And it's the only reason that I could figure that they would back up Obamacare, because the insurance companies were going to prosper. And as insurance companies prosper, the AMA is going to prosper because of the CPT coding system. So I wrote an article. It was the first thing that I published pretty widely. I think it was called "Who Stands for the Patients in the Debate on Patient Care." And it was published in the Philadelphia Inquirer. And I guess what I pointed out was, what's wrong with healthcare? Well, take a look at who lobbies in Congress. And here's the list of the top 11. And if you look at the list of the top 11 at the time, it was the hospitals, it was pharma, it was insurance, and, it was the AMA, AARP too. And we can talk about them later if you want, because more conflicts of interest abound there. And I've written about them too. But anyway, so I published the piece and I pointed it out that, big hospital, big insurance, big pharma, they've all profited since we passed the ACA. And, big medicine was in there too. But if you looked at big medicine, were they really speaking for the doctors or were they speaking for insurance? And so I pointed out their conflict of interest. And I also pointed out, and I must have had like hundreds of contacts from people that got in touch with me because they were blown away by the fact that I exposed that the AMA had 85% of doctors as members in the 1960s. And then at the time that I wrote the article in 2017, they were down to 15% of practicing physicians. The AMA would contend this and say that it's really 24%, but it's not. Even 24% would be pretty abysmal, going from 85 to 24%, right? But they count medical students and residents in there, and they pay a small fraction, and a lot of times it's paid by the hospitals anyway. So if I wanted to be a member of the AMA, I'd spend $400. If a student wanted to be a member, they'd spend $20, and a resident would spend $40. And when the hospital is paying for the residents and the students, and they're paying almost nothing, I would discount them as being actively practicing physician members because they're in training. So, so there's a lot of conflicts of interest in the AMA, and I don't think I have been a member since medical school. It's not like I'm looking to tank the AMA. I think if they wanted a path forward, they could do one of two things. They could put their conflicts of interest all over their website and tell everyone that they have them, and then maybe people would have some trust in them, or maybe not. And then they could ask people like me and Free to Care to work alongside of them when they had common agreement, because there's some things that they say that I do agree with. Or they could give up their conflicts of interest, but then they'd have to give up a lot of their money. And they already have a whole passel of it because it's sitting in, in all kinds of investments, probably offshore too, but I haven't looked lately.
It's
Yeah, I mean, it's endless. I was just thinking, I'm like, are there any areas of medicine that don't have a conflict of interest? You look at the medical journals, you look across the board, and you think, wow. As a matter of fact, I gave a talk, and I wasn't sure it was going to go over, but it was on ethics. And I said, let's look at the ethics of these things. And you look at the American Board of Internal Medicine, which I was a member of for many years before I changed my board certification, because I was reading that all the members, all the top tier, they do not have to disclose any financial gifts they receive from any entity, including pharma. If they get cars, truck, whatever, they don't have to disclose any of that. But if I can't take a pen from pharma because it's going to bias me, so I have to buy my own pens now. And you go, wow. So pens aren't, you're running the show, and you can take money from anyone. But if I take a pen, I'm going to prescribe differently all of a sudden. So it's just amazing when you see that in their bylaws, when you look at them and think, how can this possibly be? If you're the ones telling all the other doctors how to prescribe and what to do, and you're getting paid off, like that's a huge conflict of interest. And there was one thing after another. And you look at the ADA, the AMA, all these guys, and you go, man, and it's hard. I get it. Because the American Diabetes Association, on this hand, they're paid by pharma, this hand by big food. Who are you going to offend? Which of your sponsors do you not want? And so we've got ourselves into such a conundrum now.
Oh, yeah. And like, it's funny because like the general public, I guess what they think to themselves, well, if the American Board of Pediatrics said it, then it must be right, because those must be really, people that are just thinking about the patient. But honestly, like, and this goes across so many levels. I love what you said about like picking up the pen. If you get, if you get a pen, you have to reveal it. And I'm glad we had that Physician Sunshine database. So what Brian, for listeners, is referring to is, I forget what year it came out, but we have something called the CMS Sunshine database. So you can look up every doctor in America. I encourage you, look up me, look up Brian, look up Tro, look and see how much money that we have taken from pharma or from device companies, because that's all part of the public record. But it should be that we have an easily accessible database. Transparency of conflicts of interest would be a beautiful thing, so that all of America can easily see who butters whose bread. So when the American Diabetes Association opens up his mouth to say something, then the American public could be like, wow, they take money from X, Y, and Z. Maybe they're speaking on their behalf, and kind of, I don't mean to diss them. I'm sure they're upset about the price of insulin too. But I mean, we all watched the price of insulin soar. Something that costs $10 a vial to manufacture, is up at $300, and the pharmacy benefit manager middlemen are making 80% of that. And I don't know that I ever saw them say anything. I mean, aren't they supposed to be speaking on behalf of their diabetic patients? Maybe they said something and I missed it. I'm not entirely sure, but yeah,
no, they receive money from pharma. They receive money from, the grains and the vegetable oil industries. And, it's really sickening. It's not like there's been any advancement. Apparently we have blockbuster drugs, but the incidence and the average A1C has not decreased, right? So there's something inherently rotten, and it's tough to piece together. But when you step back and you look at it, it's very clear. The incentives are completely not aligned. Pay physicians for how well they do in diabetes, pay them on the delta. Don't pay them for visits, right? Don't make people come in for a visit just to get care, and then force every single major health institution to drop their conflicts of interest, right? There's no reason that they should have, corporate funding. And, particularly from fields that stand to benefit, right? So it's just, maybe we create some sort of, or at least we shouldn't trust mainstream medicine. The AMA should come out potentially and say, these are not trustworthy because they're conflicts of interest. And Gary Ruskin, at the U.S. Right to Know, is a big pioneer with Nina Teicholz and some others at exposing sort of the conflicts of interest in the USDA, previous guidelines, and certainly throughout industry. but it's not, the problem is we're not an authority. That's the sad reality, right? Why is trust in medicine down? You cannot be an authority if you're bought and paid for, right? And I think part of the problems that we have right now in medicine and the lack of trust and the politicization of medicine and how it's sort of become polarized all comes from the fact that we allowed all of these conflicts in, and we sat by and let the noble lies pass one after the other. I'm curious, where you think we stand now and what's the antidote? I mean, you mentioned that you're working, you're a big advocate of transparency, you're a big advocate of direct care, and the reality is how do we make this mainstream so that you can drop the hospital system or the corporate medical system and come join us? Like, how do we scale that in a way that you can make a living and you're not forced to sort of work in a system that is just propagating this nightmare.
Right, right. Well, look, we both know there's a lot of rules in the way. So for instance, if I decided, all right, I don't want to be employed anymore, and I work for a pretty big system that has its tentacles in a lot of places, the restrictive covenant is such that within I can't remember what it is, a 30-mile radius,
25-mile radius, something like that.
Yeah, of any single place owned by the entity that I work for, I'm out. I can't work there for 2 years, right? Because I might supposedly steal patients or something. So, if you think about
where are you located and what's the entity? Let's just go through that part.
No.
You can't say.
We don't.
Okay.
Yeah. So, I prefer not to do that.
So,
but what I would say is that for if you take a look, another trend that we've seen is we've seen a lot of patients become owned by, now they're employed by big systems, and the systems have become bigger, and then the physicians have become employed. So you either need to pack up and move your bags and move your whole family if you decide that you want to become an independent physician again, or you're stuck. You're stuck where you are because you can't leave. And the bigger the systems become, the harder it is for you to leave. So it's wild too. I mean, this even goes across the country. I don't work for Geisinger. It's in Pennsylvania, right? I live in Pennsylvania. I don't work for Geisinger. But Geisinger is really now partially owned by Kaiser Permanente of California. Kaiser took $5 billion in seed money and made something called Risen Health, and then they bought two big systems. One is Geisinger, and one is in North Carolina. I forget what it's called, but they're Cone Health. Two big hospital systems owned by one in California. So now when you have these big hospital behemoths that span the country, and then you have things called restrictive covenants, you're really boxed in. And then I guess if you are the patient, when we started some of the conversation, we talked about the fact that the labs and the x-rays and the radiology and a lot of things are more expensive in the hospital setting. If you have the big hospital setting and then the hospital's getting bigger and then they're buying the independent practices, then you have fewer independent practices. Well, then what do you have left that's less expensive for the patient? Pretty much nothing. And then they have the little contracts with the insurance companies that they're not allowed to disclose. Is it any wonder that everyone's premiums just keep spiraling up? Of course not, as you point.
Well, I think the latest stats, somewhere like 85% of doctors are employed by big corporations. I think Tro knows those data, and that means 15% of us are left.
Yeah.
And then more and more are being bought out because they really want the patients, not the doctors. Because if you're a cog in the wheel, and that was the big thing I learned over the last several years, is I have friends who work for big corporations and they're pushing certain interventions that may not be best for the patient, but you can't say anything because if you do, you're gone, and they'll bring the next person. Then what are you going to do? So
Right.
we're really hamstrung to give good medical. For me, it's like if I'm saying crazy stuff, my patients go, "This guy's crazy," I'll go somewhere else. But if you're employed, like you can't say anything. Like a lot of doctors can't talk to us because they go, "I'm employed by a big corporation. I'm not allowed to go on there because if I say the wrong thing, I'm out." and a lot of us have school debts and loans and families we got to take care of.
Yeah,
So
That ninth
it's a lot of
booster,
pressure.
that
I
ninth
was a
booster in the 10-year-old who had myocarditis last year, you mean? Is that what you're suggesting?
Yeah, that's what I'm
Uh,
saying. Yeah. And when you look at these, it's a tough thing. And, you know, there was a lot of stuff we saw as outpatient docs that you go, man, that is crazy. I had one of my good friends collapse while we were riding our bike, passed out. Anyways, gets ruled out for heart attack, gets discharged. He follows up with his primary, and his primary is mad at him because why didn't you tell me you had COVID? Because I didn't have COVID. I passed out on my bike. They checked me twice and I was negative. In the hospital billing, they put that diagnosis and they get paid more. And I had several patients that happened to that were completely healthy, not coughing, not sick, and they went in for head trauma or something. And when you see that, you go, oh my gosh, it's crazy. It's become about the money. And then like, it's just so hard because the insurance companies, and if someone doesn't have insurance, like you said, if you go to the ER for a simple thing, it's gonna be $10,000-15,000 if you're uninsured.
Yeah, actually bringing up COVID, like here was a point of distrust that just blew my mind. Now, keep in mind, I saw only pediatric patients, and by and large, pediatric patients weren't really sick with COVID, right? So I
Mhm.
never recommended anything other than supportive care for pediatric patients. In fact, because like I'm a non-pharma kind of doc, I try to prescribe as few meds as possible. Um, but in any case, I remember we watched that drug Remdesivir, the 5-day infusion in the hospital drug
yeah.
Remdesivir, kind of became the go-to drug for everyone, right? And I think everyone that was watching that was suggesting oral outpatient drugs that were cheaper, the question wasn't, to me, like it wasn't a question of, oh, we're ignoring that drug that is the perfect cure-all for COVID. I don't know for early COVID if there was going to be a cure-all, and we don't have to get into that conversation.
Mhm.
But the fact that we used remdesivir for as long as we did, because who profited off of remdesivir, which was what, $3,200 a dose or something? Who profited off of remdesivir besides the company that made it, Gilead? Well, I mean, there's middlemen that we've referenced, the PBMs, that drive up the cost of outpatient prescription drugs, but there's also middlemen in the hospitals and nursing homes. They're called GPOs. GPOs are going to make a lot of money if a hospital drug is chosen as the darling. And if it's a 5-day infusion, the hospital's going to make a lot of money because guess what? The patient's going to park themselves in the hospital, stay there, get their 5 days of infusion. I had a nurse that called me. I'm not going to say from where or from what hospital, but I think it was in, oh gosh, late 2022. The nurse said to me, why are we taking patients that have no oxygen requirement, are well hydrated, testing positive for COVID, and plopping them in the ER for 5 days for 5 days of remdesivir? And I said, well, we're doing it because they get a preferred payment because under the emergency mandate, I guess remdesivir was one of those drugs for which there was an upped rate that the hospital was collecting.
Yeah,
But
20% increase on the entire hospital stay.
and the problem was that the hospital was perversely incentivized to want remdesivir. The middlemen GPOs were, and so was the big drug company that was in there. But then I think a lot of patients understand that the drug got pushed on them, and they feel very uncomfortable about that and very angry about it. I'm not going to say I know anyone that died from getting
I have a patient with
remdesivir.
renal failure,
Oh, yeah.
from
It's very
remdesivir,
common. I mean, it's a very common. I mean, look at the
who's on the transplant list and on dialysis now.
yeah,
And he's
and that's the
furious.
thing is this was, and I'll just say it because it was a perversion of our medical system. There was people who were testing positive on a PCR test. Guess what? I have multiple patients. I'll just say it, 5 patients that I'm seeing in Prescott, Arizona, diagnosed with long COVID. I checked their nucleocapsid. They never had COVID. They have a vax injury and their spike proteins through the roof. But they're diagnosed with how can you be diagnosed with long COVID when you never had COVID? It doesn't, you can't have long flu if you never had the flu. So there was a lot of stuff like that happening. And when people were, what the thing that tells you is they were all PCR positive. That means the PCR test was not good because it was saying you had it when you didn't. And if you're basing your treatment plan on an asymptomatic person with a positive PCR test, and that's exactly what they did to several of my patients in the hospital when they weren't there for unrelated causes, that is really that's really unethical and medically that's malpractice. It really is. I hate to say that word, but it is.
Well, yeah, and then you take the patient themselves put in a rough situation. Like in all the advocacy work, I know patients and doctors and all kinds of people from all over the country. I got a call from someone that had, I want to say their child was about 18 months old, and their child was positive for COVID, positive for RSV, and positive for, I believe, rhinovirus. Admitted, they would drop their oxygen very, very so slightly at night. They were wheezing. And mind you, they were positive for RSV, but the hospital wanted to give the child 5 days worth of remdesivir. And the patient called me because they said, we're being asked to sign a waiver. And I guess at the time, the remdesivir was approved for 12 and up, and this was a 2-year-old patient. So they wanted to give a child 5 days of IV drug, which of course, the hospital was going to get a 5-day hospitalization there, right? And we knew the patient had RSV, but then I didn't want to say, I didn't want to, I wanted the patient to be able to come to the conclusion, right? So I asked my friend, what do the nurses tell you that your child is looking like? And they went back, and the answer was the child was looking like an RSV bronchiolitic, right? And so I said, well, that right there tells you if you're, because it makes sense that if you're dropping your oxygen very slightly when you sleep, and you have RSV, that's what you got. And I really don't think the remdesivir is going to do anything for that. Later, after the child recovered and came home, and I think they were home in about a day and a half after the question of the 5-day remdesivir, the patient, said to me, or the parent said to me, why would they do that? And like I said, well, what would happen to you if you signed the waiver?
We should say the honest truth. They were willing to experiment, and they were not clear about the unknowns, right? That's what happened, right? They were authoritarian. They weren't clear about this is a guess. There's 2 viruses. We don't know. This is an experimental drug with side effects. Long-term, we don't know. We've been told to use it. We don't know. And, do you want to experiment on your child? And when you frame it that way, the answer is very easy, right? For the patient, it's no, right?
It's no different than what's happening with the care of children who think that they can change their gender, right? Like the byline. Well, and I've written about this, and as I've mentioned, I'm an employed physician, but I think I wrote about it in a way where I'm pointing out that we should all care about those children, and we should all care about the side effects that happen to those children. But the byline is that it's fine to do this because we know if you take children that have precocious puberty and you treat those children with precocious puberty, they're just fine with blocking the puberty. Well, you can't compare apples to oranges. What kind of science do you call that? The average age of onset of precocious puberty is age, I believe, 7, and then you would only need to be treated for 2 years before you would let puberty progress naturally. The average length of puberty is 7 years. So how are you comparing a prepubertal child that has an abnormal appearance of puberty to children that are having normal puberty and comparing 2 years to 7? And then we don't know what happens downstream later from, the result of that. But now we're at the same perverse incentives because those puberty blockers go take a look at, what you can get for Lupron, what you can get for, what's the one that begins with a T? It's out of my mind, but there's trileptidor, I believe. So some of those medications are fetching a big price. So the people that have the children that are questioning, that are wondering if they should block the puberty, maybe they should be asking their doctors, is there some perverse incentive for you? Is there some perverse incentive for the hospital? What's everyone making here? It begs very.
Yeah, how do we get that conflict out? I mean, how do you get that out of, because you look at, we all know.
If 5 years from now they commit less suicide, we'll pay you. Nobody will do the surgery.
That's kind
if
of
5 years from now they commit less suicide, we'll pay you. And they'll
there's
give up because they're greedy and they're not in it for the patient. It's in it for this false sense of empathy right there, right in that minute. No sort of ability to step back and say, what did we get wrong here? Maybe we should sit on our hands. Right?
Yeah, but you guys are
Same thing with
metabolic
bariatric
doctors.
surgery. Pay a surgeon 5 years later if they don't gain the weight back. How many will do the surgery? How many do the surgery, Brian? Yeah, Marion, what do you think? If we said bariatric surgery,
far fewer, but here's the other problem, and you brought it up when we brought up the remdesivir and the experimentation that was happening.
Dr. Mass, I'm sorry, you got me riled up. No. You guys got me riled. I'm so passionate about this.
No, but that's okay. But look, we're also what's the downstream effect if you block a young woman's puberty, and then you do the cross-sex hormones? I mean, look, you guys, just by your gender, are at much higher risk of cardiovascular events than I ever am, right? Because I had female puberty and I got estrogen and I didn't have as much testosterone. Now, if you take a whole subset of American young women, you block their normal puberty and you give them a T, what are they going to be facing 30 years from now? Have we just made a whole bunch of more potential care that is needed for our cardiology friends? I don't know. I would guess yes. But
yeah, and it's just the idea of normal physiology, right? So people are ketogenic. They don't want to do a ketogenic diet. I'm just going to take exogenous ketones. Their insulin's high. That's not physiologically normal for your body. So there's a bad reaction to that. So if your brain's not wired to have all this testosterone, I mean, look what we're seeing in society right now. All these mass shootings, you go, why is this? Why is this happening? Because it has to be some contribution to huge doses of testosterone that your brain and psyche cannot handle. It's just not wired that way, right? Just like if you gave me a bunch of estrogen, my brain would be different. I might have a lot of changes. So yes, these things, you have to look at the risk and the benefit of everything we do. And the problem is, I think the problem is medicine has become so political where we can't say, I'm doing the best thing for my patient. I don't really care. Like in California, they passed something called AB 2098 that chased me out because AB 209 said, if you do anything that's contrary to what the governor says, then we'll put you under investigation. You can lose your medical license. If you say something on social media, I'm I have 2 podcasts. The odds are I'm going to say something to get me in trouble. And so, but it's unconstitutional. And if the governor is totally saying everyone needs transgender surgeries and all these things, and I go, I don't agree, you lose your medical license because you disagree with someone who doesn't have a medical degree. It doesn't treat patients based on what you're seeing clinically. So it's why it got overturned because it was unconstitutional. But the threat of that, you go, what are they going to do next?
Right. No, the sad part is it's we just stopped discussing, right? And yes. COVID really flew it, we had COVID and, COVID was very real. There's the people that run around and say there were, no one was really sick with COVID. Yeah, they were. I mean, it was pretty ugly and it was pretty ugly for a while, but we stopped discussing. There was one dogma and you were supposed to adhere to it. And if you didn't adhere to the dogma and you didn't mask your 2-year-old and you sent your kids out and let them go run on trails and they didn't have the mask on and you were showing up at the grocery store. If you did the things that were against the dogma or spoke for the things that were against the dogma or wanted your children back in school, or questioned whether or not everyone needed the vaccine, young, healthy people, then you were on the outs, right?
Well, and especially you as a pediatrician, because you know what you're seeing. And that's all the pediatricians I talked to said the same thing. They go, risk versus benefit. We need to discuss that and go, look, there are some things we're hearing about this myocarditis thing and heart attacks and strokes in little kids. And you go, I have to weigh that into my equation of saying, what's your risk of getting seriously sick and what's your risk of having problem by the intervention and weighing those things out and go, but we have to be able to discuss those things and go, look, here's if people say, what would you do with your kid? Right.
What was really troublesome to me too? Everyone discounted the losses that the children had. I remember, so I was on an editorial board at the time for my county. And I remember most of the people on the editorial board were much older. So there were 85-year-olds who had lived their life, who had gone to their proms and their graduations and who had got to go out on dates. And they were screaming about the fact that, these young kids, they want to go out and they want to enjoy themselves. And, I could catch COVID because of them and I could die. And I remember saying back, you understand these kids just want to live. You've had 85 years of life. I'm not telling you your life is at an end, but you could choose to stay home and not go out because you have that fear. But now you're putting this on a bunch of young people who have not had the chance to fully live their lives. It was absolutely outrageous. And I remember
yeah. The suicide rate, the depression rate, the alcohol abuse. I mean, all these things, kids were having just a fear of people. I had kids that were wearing masks and I go, are you afraid of COVID? They go, no, I just feel more comfortable now this way. That's their social, right? The impact it had on the psyche was amazing.
It was. The other thing that I'll say, and I can't blame the parents for this, and I still meet parents and we talk about it. I say to them, what I'm seeing is I'm seeing so much medical anxiety, so that when your child has a fever, I don't think of a fever as an unusual or abnormal thing. I see it all the time. And kids do fine with fevers. Of course, you may want to have your child checked out, but we went through a very long period of time where kids would come in after 30 minutes of fever and they'd want to know what it was. And I would say, well, listen, like 90% of us diagnosing something in medicine happens because of history. We have 30 minutes of history here. I don't know that I'm going to tell you exactly what the problem is, but let's also talk about the anxiety that happens when your child has a symptom that has been happening since in time memoriam. And, so I saw the parents become much more anxious about simple symptoms. And then, the byproduct is that when the parent's anxious, let me tell you, the kid's going to be anxious too. And I don't mean to be blaming the parent because they're all riled up because the media's got them riled
totally. Up. Everyone was fearful and didn't know, and we're kind of figuring it out. Yeah, so it was a stressful time for everyone. It's just you look at the reaction, you go, man, closing down all the schools, and now they're looking and saying, in retrospect, the flu is way more fatal for kids than COVID was, but they don't close the schools down now because someone has the flu. If that's your bigger, if it's about that risk, the flu is the most risky thing. So that's maybe when you start thinking this way, right? So it's just wild how we all reacted, but the effect on the psyche on kids of not being around their peers, not engaging with others and talking about their concerns, being locked in a room playing video games,
missing their sports. 80% of high school age kids play some kind of sport or do some kind of athletic activity. They couldn't do any of it. It was bad for them physically, bad for them emotionally, bad for them mentally, the whole 9 yards. They lost so much. Boy, I hope this is the direction you meant the conversation to go.
Doc, no, we appreciate. We don't want to keep you because it's so great. It's important for people to hear this. And like you had mentioned, I always forget the name of this, but like if you have insurance and you go get meds and this middleman in outpatient, so the PBM, yeah. So people go and they haven't, and my patients get upset all the time because they come back and I go, you know what, just go pay cash for this, and they go pay cash, and it's a third of the price or half the, eighth of the price sometimes of what they were paying as their copay. I'm like, wait a minute, they were charging me more for the med through my insurance than if I just pay cash. It's insane.
Yeah, well, the other thing too, and I was just on a show on WHYY, the NPR affiliate out of Philadelphia. I was on with the famous, I was the not famous person on the show, Zeke Emanuel, one of the prime architects of the ACA, and Wendell Potter, who was a Cigna exec that left and is now a whistleblower. And Wendell pointed out, and I love that he did, he pointed out that the PBMs are actually, I've been saying it for forever, they're the cash cows for the insurance companies. They're making more money for the insurance companies than the insurance component of the insurance company, right? And the PBMs own them, and they usually own the pharmacy, the big ones. They own the PBM, they own an insurance company, they own the pharmacy, and very often they own a bunch of clinics as well. So they're doing the self-dealing, and you guys brought up the medical loss ratio, whereby 80% has to go towards patient care or quality measures. That means 20% of the total pie becomes profit for them. Well, if the pie is bigger because 80% is bigger, then the 20% is bigger too, more profit, right? Yeah, so if you're paying out more, you're going to be able to profit more. And that's one part of the problem with medical loss ratio. But the other part, because they're so vertically integrated, they're basically paying themselves. So the insurance company pays the PBM to pay the pharmacy to give the medication. And if they own the PBM and the pharmacy, and by the way, they choose the drug that's on the formulary based on kickbacks because those are legal for PBMs. So they get money inflowing from the kickback, and then they're self-dealing by paying themselves, paying their PBM, paying their pharmacy, and then they count that towards their MLR. Well, the pie just got like 5 times bigger as far as I'm concerned. And so that means more profit for them.
It's such a grift.
Yeah,
it's such a grift. And I think people don't understand that. And we have to disentangle that. The best way, direct care, buy the meds, send pill packs to your own patients, get the direct meds. Even if you use Trump RX or whatever, or Lilly Direct or whatever for these GLP-1s, the immediate savings is 1/4. The immediate. So direct, I think medications is going to be the future.
Yes, Cost Plus Drugs is doing it. Cost Plus Drugs has thousands.
Yeah, Cost Plus. You will go on the other side of the aisle as well. Cost Plus is a great example. It's doing great work,
Forget the side of the aisle. It shouldn't matter. If you've got a good model in front of you,
yeah,
who cares?
Yeah, if the model works and it helps the patient, I think that's what we're all saying.
We're not about political identity. We're about outcomes. And Mark Cuban is doing a great job, in my opinion, of dismantling the PBMs. I may not agree with him on everything, but he has done phenomenal to get the grift out, essentially.
We should be very grateful, as a nation, that he's set us up there with a model of transparency, showing us that for thousands of drugs, we can save money by getting rid of the PBMs and the distributors. Yeah.
Agree.
Yeah, it's a huge deal. Awesome, I mean, Brian. These things are, thanks so much. This is really,
I'm so happy,
How about in closing?
We wrangled you down from the garden, Doc, and we got you in. So I appreciate it.
Yeah, I made you work today. Sorry. On a Friday, you believe how bad we are?
No, well, that's okay. You're busy people. So we'll tell the listeners, I did not get the email, or else I didn't see it because I've been busy catching up with everything. And I was out in the garden and I just happened to take Tro's call. Thank God. And then I said, well, I'm not prepared, and here I am. I'm literally in my sweatshirt from planting some hellebores today.
We'll take you any way we can get you. You're a warrior,
right.
And we'll definitely put the not-for-profit in the show notes and how people can follow you on X and elsewhere. And I appreciate the work that you do, the advocacy. I think the docs that are truly patient forward and see the perverse incentives, we need to come together more and more. So I appreciate you coming on, and I know Brian feels the same way.
Yeah,
my pleasure.
I just have one question for you while we close, because it's curious, because we see it. Do these doctors just not see it, or they can't see it? How do you not have a bunch of doctors out there going, this is crazy what we're doing? I remember when I was in the system, I thought, does anyone else think this is crazy? We have to have coding classes and do all this crazy stuff and deal with insurance companies and beg to get our patient the care they need. How is it that more doctors aren't saying, doctors are, I used to think, why do they even have medical ethics? Anyone going to medicine has to have ethics, or they want to go into medicine. I was like, oh my gosh, that was probably the most important class we took, and you go, how does it that doctors aren't saying, yeah, this system's really bad?
Well, look, I think that who's training them? They're coming out and they're being trained by big hospital. So they're probably not being told that there's alternative models. Actually, this is good news. In Pennsylvania, a friend of mine pushed to help get a resolution over the board, and it's now policy for the Pennsylvania Medical Society. They're supposed to help advocate at medical schools and residencies for direct models of care and other kinds of models that are independent models of patient care, and where doctors are independent again. I think that's a big positive for patients. So I guess, why don't doctors see it? I think we're busy. We graduate. I think the new young guys, I feel terrible for them. They got big loans in their mind.
Mm-hmm.
They have to learn all that coding system, and they just learn that, and they're probably not even questioning it until someone comes along and tells them different. And, I think people are busy raising their families, busy taking care of their parents, busy doing a lot of things, busy for a lot of reasons. But I think we have to have at least some of us that are going out and saying something, and then people following. We need exposure of where the problems are. We need to dissect out the useless parts of our system that are costing our patients money and not giving them care. We should ratio people, right? The amount of value they provide divided by like the cost to the system. We should ratio
I would
them.
tell
Oh my
everyone
God,
because
that's what I pitched to
That's so funny. I literally pitched that to Oz. I said the delta of the health, the delta of the health benefits that the doc, provides, the delta of the blood pressure, the delta of the weight, the delta of the A1C, divided by the cost per patient, and just put that on their website. Every single doc, by
Well, yes, but have
100% ratio.
an overarching of like, the value that's provided to the patient by the PBM divided by the cost.
Oh,
Give
I
us
thought you were talking about
You
docs.
see what I
Yeah,
mean? Like I'm talking
yeah.
like first we got to get rid of all the fluff. But anyway, we digress.
Well, and I think it's good, because there's a ton of nonprofit hospitals. I look at the in the community hospitals where I work, and you look at how much the CEOs of these hospitals are making. You go, holy cow! It's like no wonder it's nonprofit because they're taking profit. I don't know how that works. Like they're making 30 times what the doctors are making. They're top paid doctors. And you go, wow, this is just crazy. So I love your work. And it's like, I think it's just for the transparency. I think it's these things, like we need to look at this and figure out how do we save money in medicine and how do we move it forward and make it not sick care, but healthcare. How do we focus on preventive medicine? All these things you're bringing up are so valuable. So I thank you both for this hour. I greatly appreciate talking to you both. I've learned a lot.
Me
Emmett,
too.
thank you again.
Oh, it's my pleasure. I hope the listeners just feel like they just got involved in in an organic phone call chat.
That's what it was. Thank you. Thank you for spur of the moment doing it. I know it's not easy. So appreciate you joining us.
No worries. Thanks, guys. Take care. Happy weekend, okay?
You too.
All right. Bye-bye.
If you enjoy the show, please consider supporting us on Patreon by going to lowcarbmd.com.